We really look forward to hearing what is getting our doctors excited and the nurses very excited about what's new for bladder cancer patients and then what they see coming on the horizon, because I think the future is bright. I think we've seen so much in the last 5 to 7 years that it's only going to get better for bladder cancer patients as you have more options. So Diane, take it away.
I'm so sorry. Now that I've woken everybody up, it's my great pleasure to moderate this wonderful panel. So let me introduce who I have up here with me. I'm going to start with Maryland native, Dr. Lambros Stamatakis. Lambros is a urologist who joined the MedStar Washington Hospital Center in Washington, D.C. in May of 2015. And he now serves as its director of urologic oncology. He's also an associate professor of urology at the Georgetown University School of Medicine. Joining Lambros from Washington Hospital Center is Lisa Chong. She's a physician associate at the urologic oncology team at MedStar. She graduated from George Washington University in 2019 with her master's in health sciences and public health, and she's been working in urology since graduation. We also have nurse Claudette Lamoth, who's worked in a number of nursing specialties, holding various positions, both clinical and administrative. Her goal is to provide world-class evidence-based patient care and exceptional customer service at MedStar. For the past several years, Claudette's been working in urologic oncology, empowering, educating, and supporting patients and their families. We're going to be joined by medical oncologist Dr. Jeannie Hoffman-Censits. She's coming from actually Sibley Hospital in Washington, and if those of you who are local know that to get from Washington to here can take anywhere from 50 minutes to 2.5 hours. So Jeannie should be here really shortly. But we also are very happy to have Nurse Kristen Tyree. She's an upper tract urothelial cancer, UTUC, coordinator for the new multidisciplinary clinic at Johns Hopkins Greenberg Bladder Cancer Institute. And Kristen is your first point of contact for all new upper tract patients being referred to the Hopkins Multidisciplinary Clinic. So welcome to you all. Thank you so much for being here. We're going to just make this as casual, interactive as possible. The panelists will speak for a bit, and then we're going to open it up for all of your questions. But we're going to get started. And I'm going to invite Dr. Stamatakis to talk to us first about primarily diagnosis and treatment for non-muscle invasive bladder cancer, as well as muscle invasive bladder cancer. And maybe we'll just start with BCG. It's still the standard of care, but we've had some challenges. You want to talk about some of the shortages and maybe alternatives to BCG?
Sure. Everyone hear me? Okay, great. Well, first off, thank you, Diane and Stephanie and the coordinators of the summit. I mean, this is an amazing opportunity to be able to, be close with the people who are affected by this disease, and this is the reason why we do what we do. So thank you very much for allowing us to be here. So, to answer your question, Diane, I mean, just to kind of take a step back. So the management of what we call high-risk non-muscle invasive bladder cancer, it is the standard of care is intravesical BCG. And as many people in this room probably already know, BCG is an attenuated or weakened form of a mycobacterium, which happens to be the cousin of tuberculosis. And it has a very, very rich history, a lot of which comes from Hopkins, as well as my previous institution at the National Cancer Institute, where I did my fellowship. It's beyond the scope of this discussion, but needless to say, it became the standard for non-muscle invasive bladder cancer, and perhaps is the earliest form of immunotherapy. Because the way that this stuff works is there is some direct or tumor killing within the bladder, but what really does is it augments your immune system. It recruits your immune system to attack bladder cancer cells. Through what we call T cells, specifically, as well as some other immunologic methods that are beyond the scope of this discussion. So BCG for decades was the standard of care. But over the course of the past 10 to 15 years, we've had some shortages. Most recent shortage has been ongoing. And it's the way that BCG is distributed to facilities such as ours is a little bit of an enigma. There's this sort of three-tiered model, and where the manufacturer, Merck, provides it to distributors, and then distributors then deliver it to pharmacies and hospitals, et cetera. And how it's being distributed, again, is a bit of a question mark. We've had BCG really throughout the entire pandemic. We're one of the only institutions in DC that had it readily. And then 4 months ago, we hadn't had a shipment until last week. So and then there's a small pharmacy in Chevy Chase, for some reason, gets BCG, and we don't know why. So we have to often ask our patients, we'll call up Brookville Pharmacy and be like, hey, do you guys have BCG? Yes, we do. And then we have to tell patients to go get the BCG from Brookville Pharmacy and bring it with them in a little lunch bag to the hospital to be able to inject it. So it's been really problematic. Part of the reason we think for this, and not to be cynical, but a lot of it is economic. BCG, again, being an old medicine that is now off patent, is very cheap. It's about $150 per dose. And I don't think that there's a huge impetus for drug companies to continue to produce it. There's Jeannie here.
There's
Hi,
Jeannie.
come on up. Hey, she made it. Hurricane Ian did not defeat her or the traffic. All right. So to make a long story short, it is still the standard of care. However, both the American Urological Association and the Society of Urologic Oncology have recognized that this BCG shortage is something that's not going to be transient. And they've come up with different guidelines for how us as urologists in the community, how we can deal with the BCG shortage. And help people who have this disease. So instead of doing 3 years of maintenance, for example, sometimes we have to shorten maintenance to 1 year. Instead of doing full dose BCG, we may have to reduce the dose so that we can take a single vial and split it between 2 or 3 patients with pretty much similar clinical efficacy. And there's a lot, as my colleagues to my left and right can tell you, there's a lot of coordination that goes along with it. I can't just split up a dose and then save it in my pocket for 2 days from now. That dose has to be reconstituted and used within 2 hours. So I have to have 3 willing patients to come to the clinic at the same time to be able to split this dose. And that's how we've been rationing things in light of a BCG shortage. So needless to say, we as a urologic oncologic community are looking for alternatives to BCG. Part of that, before, we were trying to find alternatives when BCG wasn't working, okay? I'm not going to say when patients have failed BCG. Diane has taught me that that is not the vernacular I should use, is that when BCG is no longer working in patients, there are different salvage intravesical chemotherapeutics, different types of other drugs that can be put inside the bladder that can have efficacy in non-muscle invasive bladder cancer. And again, the population that this was initially studied in were folks where BCG didn't work, and people were still looking for alternatives to bladder removal. Well, now those same chemotherapeutics are being used in first-line settings in the BCG naive population. And Max Cates, one of Jeannie's colleagues, one of the urologic oncologists over at Hopkins, has recently published work showing that gemcitabine and docetaxel may have similar efficacy to BCG in patients who perhaps don't have BCG available in the first-line setting. The group at the University of Iowa has looked at this as well, and it looks like there could be similar efficacy. And those are drugs that, at least currently, are pretty easily available, or easily available in the community, and tend to have very tolerable side effects, perhaps even slightly better in our experience than BCG. So that's just one example of what we're looking for in the future. Not to say we're going to ever replace BCG, but perhaps if this continues to become a problem,
we may have to put out this. This is too, because it doesn't any live organism, just like I have cousins, BCG has cousins. We talked about tuberculosis, but there are other strains in BCG. The strain that we use in the United States is, again, the Merck product known as TICE, T-I-C-E. Well, there's a German strain, there's a Russian strain, there's a strain from Japan, the Tokyo strain. And recently we were very lucky to be a part of a clinical trial led by good friend Rob Svatek down at in San Antonio, where he was asking the question, well, is this Tokyo strain just as effective as the TICE strain that Merck provides? So there was a randomized trial that he came up with and was sponsored by the Society of Urologic Oncology. And basically we randomized people to receiving the Merck strain versus the Tokyo strain. And then there was a third arm where patients actually received an injection of BCG and also got an induction course with their bladder. That study filled up very quickly because we were in the midst of a BCG shortage. Rob wasn't predicting that at the time when he designed the trial, but it helped him with accrual. I believe that trial had over 750 patients and it accrued rapidly, and now we're just waiting for results. But we had about 25 patients on trial, and anecdotally, it seemed that there was, again, don't record, this is being recorded, but it seemed that the efficacy was about the same. We'll see what the data actually shows, but I did not see any major difference, at least in our patient population, in terms of efficacy and also in terms of side effects. We're really excited about that Arm 3 trial because perhaps an injection of BCG can help to prime the immune system and then improve the response rates in patients who subsequently see BCG in their bladder. And there is some data from Europe that suggests that that could potentially be the case. So we're waiting on the results on that. So that could be another way where we can increase our supply by getting another strain within the community to be available beyond just TICE. And then there's, of course, a bunch of other clinical trials that we'll talk about in a little bit.
Yeah. So staying within the non-muscle invasive area, have there been advances in diagnostic tests? I mean, I know that one thing many people would like to see is reducing the number of cystoscopies. Have we seen any changes in that, or are there changes coming on down the road?
Yeah, that's a great question. We would love that. We would love for people not to have to undergo surveillance cystoscopies every 3 to 6 months. I'm not sure if my employer would like that, but I mean, honestly, this is the reason why bladder cancer has been one of the most expensive diseases to manage, because folks have to have a procedure every 3 to 6 months for the first 2 years. It's expensive. So imagine if you could just pee in a cup and someone could tell you whether you have a recurrence or not, right? Wouldn't that be great?
Yeah.
And there are a lot of people that are looking at it, but I will tell you, CX Bladder is one that I know that we had mentioned. So it's not FDA approved. We used it. I wasn't that impressed with the results, to be very honest with you. And the thing that I really don't like about using a non-FDA approved test like that is that the patients would often get bills. I mean, just to be very practical about it. And we would have a lot of complaints.
So because it's not FDA approved, it's not covered by insurance.
It's often not covered by insurance. Some insurances will just sort of look it over and you can slip it by them, but others would be like, nope, that's not a test that we're going to pay for. So we spent a lot of time and effort, Claudette particularly, writing letters, talking to patients, often frustrated patients. Why am I getting a bill? And of course the reps would always come to you and be like, don't worry, we're not actually going to collect on that. It's fine. Just tell them to ignore the bill. Well, I mean, a lot of patients don't like that. I know that my mother always taught me, you get a bill, you need to hold true to that and pay it. You don't want a collection agency after you. So that is something that I think that the community really needs, is we need a better test that's going to provide a very accurate result. We want to know when there isn't bladder cancer present, so we need something that's both sensitive and specific. And if there is a recurrence, it would be nice to know if this is a high-grade recurrence or a low-grade recurrence, something that's going to allow us as clinicians to then prompt the next step, which would often be a procedure, and avoid having to do these periodic cystoscopies. But right now in 2022, there's nothing that really, unfortunately, is good enough to be able to, is that's good enough to be able to replace cystoscopy, and most urologic oncologists are uncomfortable with the results of a urine test at this time. I mean, we all use cytology. When cytology is positive, it's a great test, but when it's negative, you're always going to still ask this yourself, well, could there still be something there that the cytopathologist missed? And, again, just a kind of review, what is a cytology? A cytology is you're taking urine, you're centrifuging it, you're putting it on a slide, and a cytopathologist is looking for cancer cells that they can detect within that slide. Well, what happens if that slide just, I don't know, was processed funny, or maybe the cytopathologist is having a bad day, or maybe they are seeing some atypical cells that may just be inflammatory. So it's not a perfect test, but if it's positive for me, that definitely helps me to know something is going on. If it's negative, I often will ignore it.
And how about, what are your thoughts about genetic profiling of tumors? So let's say you've had a resection. Are you doing that for your patients?
For non-muscle invasive bladder cancers, we haven't. I think that is something that, some of the folks that I know within the urologic oncology community are doing, including my good friend Seth Lerner, who's big in the leadership within the BCAN organization. And it's something that I think is going to be in the pipeline very soon. Imagine in a scenario where you could profile a patient's tumor and tell you a lot more information than just this is low grade or high grade. Imagine if you could just say, your tumor is not going to respond to BCG, so let's just skip BCG, right? Let's do something that's more targeted. Maybe an agent that we don't even use right now for intravesical chemotherapy, that could be the agent that perhaps would work well for you. That's what the future is in this field, and I think it is something that is very feasible to do. We're able to easily access tissue for genetic analysis, and I think that it is something that in the future will become something that will be clinically actionable. But right now, we don't use it for non-muscle invasive disease. Certainly for metastatic, and I think Jeannie will go through that in a little bit. There's a substantial role for it, but for non-muscle invasive, it hasn't quite trickled down. Usually, what ends up happening in cancer care in general is we figure out all kinds of great stuff in the metastatic setting, and then it trickles down to the localized setting. So then I get it, a couple of years later. So Jeannie gets to become famous about it, and then a couple of years later, it'll be like, oh, I'll use that stuff that Jeannie was using 3 years ago in the metastatic setting.
So one of the big changes I've seen over the last 15 years for muscle invasive bladder cancer is the greater acceptance, or at least willingness to try modality therapy. With somebody with muscle invasive bladder cancer, you don't immediately have to go to removal of the bladder. Can you talk a little bit about trimodality and who would benefit, whether or not
Sure.
you all are doing it?
Absolutely. So when I trained, bladder preservation therapy for muscle invasive disease was simply something that you would give to an individual who was too sick to have surgery. So at our VA in Houston, which is the largest VA in the country, we'd see an old frail person in a wheelchair with oxygen who couldn't walk 3 steps, and he was diagnosed with bladder cancer. Send him to the medical oncologist and see if they'll do chemotherapy and give him some radiation. That was the only reason you would do anything for that patient, or you would not offer you would not offer trimodality bladder preservation therapy. But now in 2022, and really we need to thank our colleagues up in Boston. They were the ones, Bill Shipley and his group up there, who looked at this and asked the question, well, could we perhaps get equivalent results to radical cystectomy, which has always been the gold standard of care for muscle invasive bladder cancer? And indeed, if you look at some of their data and compare it to the outcomes of major cystectomy series out there, the oncologic outcomes, the cancer-specific outcomes, are pretty darn close. They're pretty equivalent. And some of these patients also have really, really good urologic quality of life afterwards, meaning their bladders can actually function pretty well. And we've seen it in our patients, where some people, if they respond really well to the therapy, we can spare their bladder and they can still have an adequate reservoir to be able to do what we do on a daily basis, which is go to the bathroom. But you have to, I think the key is patient selection, and people have to understand that not every single patient is going to respond the same way. All right. So what I mean by patient selection, I think the ideal patient that for trimodality bladder preservation therapy, when I mean trimodality, let me just take a step back. It's a combination of doing a resection where all grossly visible tumor is removed from the bladder, followed by chemotherapy, systemic chemotherapy, and radiation to the bladder. So those are the three things that are part of trimodality therapy. So a maximal TURBT is what you'll see in the literature. And so again, removing all that tumor, followed by chemotherapy and radiation. So if you have a patient who has a lot of multifocal disease, a lot of different tumors within the bladder, that patient perhaps may not be the best candidate. If you have a patient who you simply cannot get all the tumor out, there's so much tumor. We saw a guy today has about 9 centimeters of tumor in his bladder. I can sit there and resect him on 3 different sessions, perhaps, and maybe get his bladder pretty clear, but that patient's probably not going to do well with trimodality therapy. Patients who have carcinoma in situ, which is a high-grade, non-invasive variant of bladder cancer, not really a variant, it's sort of a precursor of high-grade invasive disease. Those patients have been shown also to perhaps not do quite as well with trimodality therapy, although there's some emerging data that perhaps that isn't a contraindication. And patients who already have poor bladder function. So if you've got a patient who's already going to the bathroom, 6 to 7 times at night, or have small bladder capacity, we're going to make them worse with this therapy, at least initially. Radiation really creates sort of like a Chernobyl effect within the bladder, and it can be quite impressive. Again, we have a patient that we can talk about a little bit later who we're dealing with currently who has significant lower urinary tract symptoms, really wanted bladder preservation, fit all the criteria for a clinical trial that we have, and now is really having even worse lower urinary tract symptoms afterwards. So he probably wasn't the best candidate for trimodality therapy. But I do think that it's a very viable option. I teach our residents and fellows that should be part of the discussion for every muscle invasive bladder cancer patient you have. I usually say the gold standard has traditionally been radical cystectomy with consideration for upfront chemotherapy, otherwise known as neoadjuvant chemotherapy. But a viable alternative, and also should be considered standard of care, is bladder preserving trimodality therapy. And then we look at that patient's particular case and go through. This is why I think maybe perhaps you're not the best candidate for bladder preservation, or hey, maybe you would be a really good candidate because you have a unifocal tumor that can be completely resected and you have good bladder function and are relatively asymptomatic. Maybe we could save your bladder in this particular case. I think the next step to trimodality therapy is how do we even improve on the outcomes we have now? And that's where we start thinking about perhaps combining an immunotherapeutic with chemotherapy and adding radiation. And I think that Jeannie can probably talk a little bit more about this too later on, but there is some thought about immunotherapy works basically by inciting an immune response, but when there's a presence of something called an antigen, that is something that is released by the tumor that the body recognizes as foreign. Well, when we start doing all these things to the bladder, like radiation, and I resect the living daylights out of it through the bladder, it releases these tumor antigens. It's a setup for a good immune response. So if we can kind of push the immune system along by giving an immunotherapeutic, perhaps that could improve on the results that we've already seen with just traditional chemotherapy, radiation, and perhaps make those results even better. So I think that it's here to stay. I think you have to go. The thing is, you have to, in my opinion, you have to be at a center that really has good multidisciplinary care so that everyone's on the same page. I've seen some disasters occur where people are like, well, I really like my medical oncologist who has an office 5 minutes away, so I'm going to get my chemo there. And then there's a radiation center that's 3 blocks down the road. I'm going to go there for the radiation, and nobody's talking to each other. That's a setup for disaster. You really need to be at a place where everyone knows each other, they're talking, and everyone's on the same page in terms of therapy. So I think in my experience, that's how we've had good success with trimodality therapy.
Great. Well, that's a wonderful lead in to our other doctor on the stage here, medical oncologist, Dr. Jeannie Hoffman-Censits. She's a GU cancer specialist at Johns Hopkins in Baltimore and also at Johns Hopkins Sibley in Washington, D.C., where she came from today. She cares for patients with urothelial cancers of the bladder and upper tract, and she serves as co-leader of the Women's Bladder Cancer Program at the Johns Hopkins Greenberg Bladder Cancer Institute. So welcome, Jeannie. So, you'll have to, I think, turn that one on. Thank you. Okay, so we're going to change a little bit here, but I think it's a great transition because when we're talking about multidisciplinary care of bladder cancer, which is something BCAN has been pushing for since the beginning of time, because when I first started in this field, bladder cancer was seen only as a urological disease, and urologists and medical oncologists didn't even play in the same sandbox. So we made it a point to make sure to bring them together. It's one of the things that our annual think tank meeting does, to make sure that the patient is being seen in the whole and getting the benefit of both the urologists, the medical oncologists, the nurses, the physician associates, the radiation oncologists, so that all those great minds together can look and can work together and find out what the best possible alternatives are for every patient. So we're going to switch now to our medical oncologists. And I know we don't have a lot of people in the audience with upper tract, but I think it's really important. BCAN also likes to address the things that aren't always getting addressed. And since we have a specialist here, Jeannie, can you provide a brief explanation of upper tract and how the testing and maybe treatments have changed over the past few years?
Sure. Thank you. Well, first of all, thanks so much for allowing me to be here today. I'm a huge fan of BCAN and all the work that you do. I was sitting here thinking about, if somebody started something, over a decade ago, almost 20 years ago at this point,
Yeah,
right?
17. Yeah.
Like, how many people start something and it's successful and then it keeps going and it builds and it turns into what BCAN has turned into? So again, congratulations and thank you for everything, everything that you do. I talk about BCAN with every single new patient. I tell patients that internet is a dark and scary place, and BCAN is a safe place for you to go. So thank you. Thank you for everything. So, urothelial cancer, very common. To have non-muscle invasive disease is the most common kind of urothelial cancer. But, the urothelium is this contiguous organ. So it lines the inside of this muscular bladder wall. But then above that are the ureters, like straws, that connect the kidneys down into the bladder. And that top portion is called the renal pelvis, which is a little reservoir. When the spongy part, the kidney that makes the urine, dumps that urine into this reservoir called the renal pelvis and then down into the ureter. If someone gets a cancer in the spongy part, which is the kidney, they go to a different doctor at Johns Hopkins because we're so kind of pigeonholed and specialized, but it's a completely different tumor altogether, right? But the urothelium, this contiguous organ, we kind of extrapolate how we treat upper tract urothelial cancer from bladder cancer. And the reason we extrapolate or we borrow that data is because when you think of every person who develops urothelial cancer across the country and across the world every year, the majority are getting urothelial cancer in their bladder. We think the biology is somewhat different. We're trying to understand it a little bit differently, but there's some different challenges that patients face when they develop tumors in the upper tract. So if you imagine what that anatomy looks like, you can have an obstruction or a blockage where the urine is coming down from the kidney where it's made and then going into the bladder. So in addition to the other medical challenges and issues that our patients face when they walk into clinic, there's age, there's medical comorbidities, hearing issues, renal function issues, cardiovascular issues, peripheral neuropathy, all the things that come into play when we're making treatment decisions. And patients with upper tract urothelial cancer, they can often come with these kidney function issues that are related to the tumor itself. So that's a special issue. The standard of care at this point for either a high grade or a low grade tumor, but particularly for a high grade tumor, is a nephroureterectomy to take out that kidney. And so that's another challenge that we know that's in the future, that a patient that has maybe reasonable kidney function prior to surgery, when they have two kidneys, post-surgery is going to have most likely a decline in their kidney function when they have one usable kidney. And then, of course, our standard of care chemotherapy for high-grade upper tract urothelial cancer is using a platinum-based chemotherapy that's both metabolized by and potentially toxic to the kidney. So it's like super straightforward when we're trying to, have this conversation in clinic. But I think the important things are a few things. So number one is that people are paying attention to this. And thank you again for shedding light on this. We think of upper tract urothelial cancer being a rare malignancy, and it is when you look at it in terms of the people who are first being diagnosed with urothelial cancer. That's their first diagnosis. If you take all those people and you put them in a room, the corner will have upper tract urothelial cancer. But because these tumors can be really difficult to stage, it's hard to get biopsies. Lambros can tell us more about that. I imagine it's like going into a cave and trying to get a little tiny piece of tissue and not damage the organ that you're going into, because every time you go into a ureter, you can cause inflammation and strictures and worsening kidney function. These are hard biopsies to get, and we have challenges in trying to what we call clinically stage patients and then determine what's the best treatment option for them. In addition, patients who have tumors in these locations, those tumors can be more aggressive. They can act more aggressively, whether or not that's biology, whether or not that's some biases with treatment, and whether or not they got preoperative or postoperative chemotherapy, it's hard to say. But then when you take all the patients that have metastatic urothelial cancer, and then you look and see, well, who had bladder cancer at first and who had upper tract at first, those numbers in terms of upper tract patients really go up. And in fact, in some of the studies with enfortumab vedotin, which is a new antibody drug conjugate, one of those studies, 43% of patients had upper tract disease. That's a lot, right? So I think that to keep calling this a rare tumor is not necessarily the case. It comes in the context. One of the other things that's happened over the last couple of years that's, I think, put the conversation on the map is our colleagues in Europe, who have done this remarkable randomized phase 3 trial called the PALT trial, where chemotherapy following surgery for upper tract disease was used to see for patients who were selected to have a high-risk tumor. You were worried that that cancer was going to return or metastasize later. Half the patients got chemotherapy, either carboplatin or cisplatin, depending on what their kidney function was, essentially, and the other half were observed. And it turned out that giving chemotherapy in the postoperative setting really did elongate or prolong what we call disease-free survival at the time that the cancer would come back. So that proves kind of what we already knew about urothelial cancer in general, is that platinum-based chemotherapy, no matter what kind of cancer you have and in what setting, it seems to be beneficial. Some of the work that we're doing here in the US and at Hopkins and in our cooperative group setting is using that chemotherapy prior to surgery with the idea of doing a few things. Number one is giving the chemotherapy when kidney function is better and hopefully it's more tolerable. Number two, giving the chemotherapy in a setting where when the patient is planned for surgery, if I give the chemotherapy and Lambros takes out the kidney, that our pathologist can give us feedback and tell us, was this a tumor that was chemo responsive? And in some of our colleagues, Jonathan Coleman's work at Memorial Sloan Kettering, they've shown from their study that if a tumor melts away, like bladder cancer, the prognosis is likely better. But if the tumor doesn't melt away, then maybe we have another shot on goal to give a postoperative therapy. We can think about that. So I think that these strategies and these clinical trials that we're doing in the space will hopefully answer some questions that are still remaining about what's the optimal way to treat patients with upper tract disease.
And so my late husband, he was first diagnosed with upper tract disease. So
I never knew that.
Yeah. So the first thing he did, what happened was he had his kidney removed. And then the cancer came back in his bladder about 9 months later, but then it had already metastasized. But so a question I have is, since what's the likelihood of people who've had start with tumors in their bladder that with a recurrence, it might be in the upper tract?
It's not as much, but it's much more common for people to have an upper tract urothelial cancer and then it comes down into the bladder. And I think this is a really important point, and thank you for bringing up the thought. So if you have a high grade tumor that's in the upper tract, the only place that the urine goes is kind of down, unless you have a percutaneous nephrostomy tube that comes out the back, and you need that for obstruction. But for the most part, these tumors are kind of being carried from the urine down into the bladder. They're setting up shop, and potentially, and then eventually being urinated out. Because of that, we know that in patients that have upper tract disease that have a nephrectomy, our colleagues in urology are also doing surveillance cystoscopies, or looking inside their bladder to see if they're developing a bladder cancer later. Then I'm also doing CT scans to see whether or not they've had a tumor that's moved or metastasized. Those are actually kind of two different disease states. And in fact, in our clinical trials, one that we're running now through the ECOG program, what we're trying to understand with the chemotherapy and the immunotherapy that we're giving prior to surgery is, does that treatment prior to surgery prevent or delay what we call event-free survival? But those events are dying of cancer, of having metastatic disease. We almost expect that in a certain percentage of patients, we're going to see these non-muscle invasive tumors in the bladder that tend to be tumors that are much easier to deal with and don't move or metastasize, and can be treated with intravesical therapy while we're using systemic therapy. So the implications of the tumor that comes back in the bladder after having a nephrectomy are quite different than tumors that can metastasize after a nephroureterectomy.
Okay. Yeah, great. So changing from upper tract to locally advanced and metastatic cancer, it's exciting to see that we have so many more treatments available today than we did even 10 years ago. Can you talk about some of those changes and also the impact it's had on how you care for your patients?
Yeah, absolutely. And I think, thanks to BCAN, thanks to a lot of people in this room, and thanks to a lot of people online, all of the things that we know about how we're supposed to do what we do is based on patients and families that participate in clinical trials. So, for everybody who's done it, for everybody out there, for everybody who's driven anybody to, a treatment visit or supported anybody in any way, the only way we know to make things better is through clinical trials. So thank you to all of you who've participated. So we've had some really striking clinical trials that have changed the way that we practice medicine in bladder cancer, since you and I have known each other, which is not that long, when you really think about it. And it's very different than, in training. So I remember, a state that was not that satisfying would be to give preoperative chemotherapy for bladder cancer. Look at your post-chemotherapy scans. Hopefully everything looks okay. There's no reason that the patient wouldn't go to surgery. They have their operation. Lambros and I would talk about the past report, and maybe it's unexpected. Maybe, scans look great. Patient felt well after chemotherapy, but instead of a complete response, it happens about 38 to 40% of the time. There's lymph nodes that are positive. There's a tumor that's broken through the bladder wall. That's disappointing. Someone just went through all that chemotherapy, and this tumor has lived through that event. And not only that, moved into lymph nodes. It's an unexpected, event afterwards. Prior to some of the newer things that we can do in the postoperative setting, a patient that had a complete response after pre-op chemotherapy and surgery, where the tumor just melted away, and a patient whose tumor lived through all that, and despite that moved or metastasized into lymph nodes, the outcome was the same as I gave them a prescription for a CAT scan that said, you're going to come back in 3 months. But because of some research, a randomized clinical trial that was done using immunotherapy in the setting for those patients that had the high-risk tumor, we were worried that the cancer came back. We now have really compelling data that shows that for those patients that either couldn't get preoperative chemotherapy or got preoperative chemo and you're concerned about the cancer coming back, that we can offer a year of postoperative immunotherapy. Again, a completely different weapon to try and control the cancer and to decrease the risk of recurrence. So I think that's a huge step forward, and something that we have not had before. So it's not for everybody. And I think that there's a lot of caveats around it. And there's a lot of people talking about it, on Twitter and other kinds of things. But I do think that it is something that we can do that can benefit patients and change the landscape.
And so for patients with metastatic disease, they either had their bladder removed or they did not. They have metastatic disease. There we go. There are a lot of treatments out there. Is there an established sequence or order in which you should try the treatments? Like what comes first, what's second, what's third?
Yeah, what a great question. I kind of think of this and I don't know. I think in simple terms, but right now I kind of feel like it's a bit of a yard sale. There's all these choices. We didn't have choices before. So now we have all these choices, which is amazing, right? But we're not really sure how to use these things in order. And the order will probably change, which is a good thing. Because
does the order depend on the patient?
It does. It does to some extent. And it does also depend on the tumor to some extent.
Okay.
And the pendulum has shifted a little bit, I think for the most part currently, and this may change in days, weeks, or months, that currently, if someone has metastatic urothelial cancer, we believe that the best thing for anybody who can get chemotherapy, whether that chemotherapy is carboplatin or cisplatin, is that they would start with chemotherapy. And the reason for that is that generally across the board, the response rate or the likelihood that we can stabilize or shrink the tumor down is going to be higher with chemotherapy. We also now have the opportunity to try and maintain a remission or any kind of control that we get with the cancer with immunotherapy. And that's a little bit different than we had before. Several clinical trials have been done around the globe, and some are still completing, looking at, well, can you take that and just mush it together? Can you just give everybody the kitchen sink? Like what happens when you do that? Because in lung cancer, you can do that and the outcomes are pretty decent. And for reasons we don't completely understand, when you do that in bladder cancer, when you give everybody a platinum plus an immunotherapy together, the outcomes in bladder cancer aren't necessarily different. So the current standard of care is to give chemotherapy to patients who can tolerate it, 4 to 6 cycles of a platinum-based chemotherapy, hopefully maintain and try and get some degree of control, and then again, prolong that control with immunotherapy. There's a select group of patients, either based on the patient or based on the disease, that you may want to offer immunotherapy alone first. I would say that's going to be a minority. So that population is one, patients who clearly cannot tolerate chemotherapy. We have a lot of 90-year-olds who come into Sibley. They're amazing, but I'm not really sure that any of them can quite tolerate chemotherapy, or patients that have poor kidney function, or patients with really poor functional status. We're worried that any chemotherapy toxicity may really impair their quality of life and their ability to come back and get treated. So it's that population of patients or a population of patients that may have a specific kind of metastatic disease. I think one of the things that we could probably do better is change the word metastatic, because it means something different every time I use it, depending on who I'm looking at. So there's someone who has metastatic lymph node only disease, where maybe they've gotten 5-second opinions over 6 months and have 4 CAT scans that haven't shown anything different. That patient has metastatic disease, but so does somebody who has, a cystectomy and 2 months later has a tumor that's moved into the liver after chemotherapy. That's a very different definition. It's a different patient population. But in someone that has lymph node only disease, and if we have biomarkers that show that that tumor is likely to respond to immunotherapy, as a high, biomarker for PD-L1, or the tumor mutation burden is high, or they fall into this very kind of small category of patients that have this thing called microsatellite instability, all the things that make you think that the immune system is ready to go to jump on that tumor if only it can be released by immunotherapy, then that may be a person that you would forego chemotherapy first. But for the most part, we're using chemotherapy followed by immune therapy. And I know that this is a really long and rambling answer, but this ability to use immunotherapy to maintain control after chemotherapy, I think that's a big deal. And that clinical trial that showed that we could do that with a drug called avelumab, I think it's a big deal for a couple of different reasons. So number one, large randomized, clinical trial that showed a survival benefit. That's a really big deal. So when we move the needle in that way, these are important landmarks and changes that we have for our patients and things that we can do for our patients. But the prior paradigm was that we would give chemotherapy to the point where someone could tolerate it, up to 4 to 6 cycles of chemotherapy. You may or may not get some degree of benefit. If someone didn't have a complete response, which is pretty rare with chemotherapy, platinum-based chemotherapy, the likelihood is with time, weeks, months later, that the tumor would start to grow again, and then you would try and chase it with something, chase it with immunotherapy or other things down the line. Now the paradigm is different. So if you can get into some degree of control or remission, and then pull that control along with a drug that's usually better tolerated than chemotherapy, someone can start to feel better as they're getting a second line agent. And you can tell pretty soon if the cancer starts to grow, then that cancer is not going to respond to immunotherapy, and you can start thinking about the next thing. If the cancer stays in some degree of control or goes into a deeper remission, then you know you're on the right track. So that period of time, I think, is very important, because we know a lot of patients with metastatic bladder cancer, because of all the different comorbidities we talked about before, were never well enough to get the second line, the third line, the fourth line treatment. But now with this strategy, we can actually get to the next thing a lot faster. So
So we talked briefly with Lambros about genomic profiling. So wouldn't it be great if all patients could have their tumors profiled? And so I would know. How close are we to knowing if I get my tumor genomically profiled? How close are we knowing to what I might respond best to?
Yeah, I don't think we're close enough. Unfortunately, we can do the genetic testing. So if somebody has metastatic urothelial cancer, if they have chemotherapy, and after that chemotherapy, a pathology report shows at the time of surgery, lymph nodes are positive. In our minds, that means that the tumor was refractory to chemotherapy. And so in those situations, because it's a high-risk setting, we will send off this genetic profiling. And it's an expensive test. Like Lambros said, we don't want anyone to ever get a bill. There's enough in life with cancer that's upsetting. The last thing we want to do is add financial toxicity and concern. So we try and order the test in the setting that we know it's going to get approved. What I'm looking for is, does my toolkit get expanded? Does the tumor have an FGFR mutation or fusion? And if it does, that means there's an FDA-approved targeted therapy called erdafitinib that's going to be on the list of things that I can use. Currently, the FDA says that erdafitinib can be used after another therapy. So it's like number 2 in my mind. So to your point of sequence, is there a specific order things can go in? There is a bit of a needle to thread. Mm-hmm. And that's one of the definitions of how we figure that out.
Okay. Yeah. I'm going to open it up to the audience in just a minute, but I want to, since we have our wonderful nurses and physician associates up here with me, I want to ask you a couple questions, and maybe start with you, Claudette. And what are you excited about? What do you see coming down the pipeline in terms of treatment for bladder cancer patients? Or what would you like to see? Either what you see or what would you like to see?
What I would like, so something that's exciting that Dr. Stamatakis spoke about are some of the options for trimodalities, mm-hmm. and getting the patients into medical oncology, getting them to radiation oncology, and work with them, collaborate with them on the patient, on their families, and let them know the other options that are out there once they progress to cystectomy. Some of my patients have told me to tell bladder cancer patients that there's life after bladder cancer, after cystectomy, that they can go on and have a full life. So I'm always sharing that. And something we do at MedStar that I think is exciting is whenever the patients progress to needing cystectomy, we have what we call testimonial list. So once the patient have gone through surgery, we would say, well, are you willing to share your experience with someone else? And we have a nice long list of patients that speaks to each other. And I truly believe that's very helpful. It helps with making decisions. And so I'm excited about that, because we try to pair up the patients that we think would have similar, not necessarily background, but personalities. And that's exciting. And they would come back and say, I would say, tell me after surgery what your thoughts are, how, based on what you were told prior to surgery, what is your experience? And what should I change? And what are some of the other questions I should ask going forward? So I have ongoing conversation with patients, and they give me feedback and give us feedback. So there are many exciting things, but I truly like, yeah.
I mean, one of the things I wanted to add that Claudette it really plays a huge role in, and probably would not talk about it herself, is this whole idea of survivorship, right? So it's that the idea of how do you continue to live once your disease has been seemingly eradicated. And, you know, that human touch, that ability to connect with a patient and to deal with some of these issues that as a surgeon, I mean, people just basically call me like a glorified plumber. I'm just thinking what scope I can insert, how I can divert urine. I have someone like Claudette who can actually sit down and have the time to talk to a patient and say, all right, what's going through your mind? Like what exactly can we do? What resource can we provide for you that will help to, maintain or improve the quality of life that you have? Living with the new normal, as I think is something that Diane and her team have kind of come up with. And the other thing that I think would be exciting, and you've actually brought this up to me before and actually have educated me quite a bit, is we are very archaic with the way that we deal with urinary diversions, particularly, cutaneous urinary diversions with bags. I mean, that technology really needs to be improved. And, one of the things that, right? I mean, trust me, I sit down occasionally over drinks with some of my colleagues at these meetings. I'm like, man, we have got to figure out some better way to deal with this. I mean, the answer isn't just, doing an Indiana pouch on everyone and having, catheters. I think there's got to be something better. And, but, like one thing I remember you taught me about is that, those samples of, what are they called? Stealth belts. I didn't even know what a stealth belt was, right? I mean, these are things that we're not taught in medical school and urology school, I mean, it's in, I saw this patient, she had this form-fitting dress on. I'm like, man, you look good. Like, what are you doing? Like, you can't even tell that you have your conduit. She was like, oh, Claudette gave me the stealth belt. Like, what the heck is a stealth belt? So, I mean, again, it's a small thing, but it's actually huge. I mean, that improves that patient's quality of life. She's a ballroom dancer and has gone back to her ballroom dancing classes. And, there's a perfect example of someone in the audience who does that too. We have a patient too. We'll hook you guys up. But I think that, those are some of the things that excite us that are perhaps simple. Maybe they're not, a microtubule inhibitor, et cetera. That's really, much more cerebral than me. I'm just thinking about ways that we can get people to feel normal again. And that's what gets us excited. I know we continue to have conversations about that all the time.
And Lisa, how about you? What are some of the questions or concerns, or what are the things that you've learned about the needs of your patients?
I think for me, it's usually when we have our first counseling with patients, they get anywhere from 0 to maybe 100% of the information, but they'll go home, they'll go on the BCAN website, they'll Google search, they'll go down this rabbit hole and find every article. And then they'll want to have, conversations about all this literature that they've read, and, just being able to provide open communication for patients, especially if Dr. Stamatakis is in the OR and they were like, well, I read, if I get BCG, then I'll die, if I get sepsis. And then, having that conversation with them, well, it's very rare, there's ways you can, avoid and prevent, and different things that we do. I think it's exciting just to be able to communicate with patients and kind of help with their anxiety, especially with any new diagnosis.
Yeah, because we all know that when you first hear you have cancer, you basically don't hear anything else after that.
Yeah.
And one thing to add with Lisa is our BCG/intravesical chemotherapeutic queen. And I think it is important to have someone who has experience with doing that therapy. And, sometimes you go to a urologist's office where a medical assistant is the one mixing the stuff up and shoving this catheter in. And that is a different experience than someone who can troubleshoot and be like, okay, well, this didn't quite feel right. Maybe I should try this catheter next time. Or, there's all kinds of things that we can do to make that experience a little bit more pleasant. And I cannot tell you how many times that people thank me, not for what I do, but for having her on my team, because they're the ones that really are getting these patients through the therapies. I'm the one that causes trouble. So really, they're the ones that are getting them through. So I think that really does change things.
So speaking about people getting patients through, Kristen, you're here representing a multidisciplinary clinic. Can you talk about some of one thing, either what you love about what you're doing, or some of the challenges with patients entering the multidisciplinary clinic? Even though it's for upper tract, it's still multidisciplinary.
Okay, I'm not used to speaking into a microphone, so sorry. I'm going to try to not be too loud. So first, I want to thank Diane for hosting this. This is just amazing. I've worked in oncology for all of my career, and I've never seen something like this where patients are so engaged and the providers are so engaged. It's amazing to have that kind of support. And in my role, whenever I educate patients for their first visit with us, I always give BCAN information because I give the survivorship to survivorship. Yeah, I give the survivor to survivor information because I think one of the most valuable things is meeting someone who can meet you where you are, see you where you are, and say, I see you. This is hard. You don't have to do anything with me besides just be you. As for my role, and something I'm excited about is I'm excited there's people like me and Claudette and Lisa who are here to help you and to kind of be on your team. When I meet the patients for the first time, the first thing I emphasize is, one, our team's awesome. And then two, I am their teammate before I'm anything else. And that the expectations for the MDC is I'll handle getting the pathology. I'll handle getting your scans. I'll handle getting the slides. I take all of that away from you so you can focus on what your goals are right now. I think that having, Lambros mentioned this, Jeannie did too. I think having a multidisciplinary clinic where all of your providers talk and all of them are in the same spot is insanely valuable. I think that the patients that we've had so far love that both of them go into the room and they talk with them and they feel seen. And then I follow up with a call and I see if they have any questions, because like Diane said too, you hear cancer and you go to the appointment and you check out. No one expects you to kind of retain everything that they tell you. That would be insane. So I get to call you. I always tell people to make a list of the questions they have, and I'll go over them like a few days later. So you have time to think, to kind of digest, and to decide like, what do I want to do? And I think that one of the most exciting things, and people are going to be shocked, but I think like the chemotherapy and immunotherapy options we have now are amazing. The things Jeannie can do, is phenomenal. How she mentioned enfortumab vedotin, I've seen people do wonderful on it, and having these kind of options is amazing for upper tract, for clinical trials. Just seeing how people are doing is phenomenal. So I think that's some things I'm excited about.
That's great. That's great. So now I'd like to open it up to you all for questions, and we have our roving mic.
This isn't, hello? Yes. This is just a thank you to Lisa, Claudette, and I apologize, I don't know your first name. As a patient, when I heard stealth belt, I have my bladder, but I had, after my TURBT surgery, I had to go home wearing a catheter with the big bag of urine. And I'm going to get choked up, but my little granddaughter was coming over and how am I going to hide this? This is going to frighten her. But it was someone like you three women that said, wait a minute, we'll get you the leg bag. I didn't even know what a leg bag was. I had this big one. Well, I found out there's a small one that I could wear under a pair of sweatpants. She didn't know a thing about it. I was more comfortable. But these are kind of things that our nurses and some of the practitioners know about and share. I love the physicians, don't get me wrong, doctors, but it's that kind of stuff. So I want to say thank you for things like that you do, really.
Is there a causative relationship between bladder cancer and cancer of the appendix?
It's a great question. And one of the wonderful things about BCAN and being able to interact with patients and all kinds of colleagues is that we're faced with questions every day that I've never heard before and I don't know the answer to. So that is a question I've never heard before and I don't know the answer to. No, but it's interesting. Cancer of the appendix is, as far as I know, pretty rare. It's a different kind of cancer, really. Wow. But we do know that there are certain things in people's lives that may put them at risk. So, we've taken care of patients that have had testicular cancer maybe 50 years ago. And back in the day when, radiation fields were larger and doses were different. And, I bet we've both taken care of patients that have a tumor in every location, up and down that radiation field. Patients who've gotten chemotherapy in childhood for different reasons, develop cancer later in life. So right. And whether or not there's a predisposition genetically that might put somebody at risk for multiple cancers, or, in our consent discussion for chemotherapy, my last thing is in getting this chemotherapy with the goal of improving your overall survival may put you at increased risk for cancers later in life. Okay, let's move on to the next thing, So it's possible. It's possible. And our technologies and our treatments have to be better so that hopefully the next decade we won't be having that conversation. But it's a wonderful question. I don't know the answer.
Questions up here?
Hello, I have a question for Dr. Hoffman. Of your patients who are on erdafitinib, so I have metastasized bladder cancer, and I've tried immunotherapy, that didn't work, and now I'm on erdafitinib. With the patients that you have who are in that situation, what kinds of side effects have they talked to you about? Because I've had a lot.
Sorry. Is it a good time to talk in general about that later line therapy? So this is a great introduction to, I think, lines of therapy after immunotherapy and chemotherapy. So our current options are the targeted therapy, erdafitinib, which is an oral anti-FGFR2/3 inhibitor. So it's our only oral medication. I think when patients hear, oh, we have a pill for you, automatically there's a suspicion or a feeling like, oh, it might not be as toxic as chemotherapy. And unfortunately, it's not true, right? So we're getting a no. I have a few patients that have been on every line of therapy, including erdafitinib. And one of the things they say is that they think about having cancer every single day because, one, they have to take the pills every day, but two, that there is, a unique toxicity profile. So in this kind of targeted therapy, as well as others, you can have some toxicities that are somewhat unexpected by kind of like turning off that pathway. So the reason the drug exists is because some tumors, more low-grade non-invasive tumors, but some high-grade metastatic tumors and more upper tract tumors are driven by this FGFR3 pathway. So it's this discovery of understanding how tumors tick, what makes them a tumor and what's different than a normal cell that led to this discovery, right, of this drug. But at the same time, it has some unique toxicities. So gastrointestinal toxicity, some nausea, some diarrhea, some skin toxicity, a very unique ocular toxicity called centroserous retinopathy, where you have to go to the eye doctor, and then hyperphosphatemia, which we believe is maybe what we call a biomarker. So if you have hyperphosphatemia, at least with a cousin drug called infragratinib.
What is hyperphosphatemia?
Oh, elevated phosphorus level.
Okay, thank you.
But you have to, so the drug increases your phosphorus level, and then you have to try and bring it down with diet, which is annoying for the patient, as well as medication. So it can be a lot, but the response rate of the expected shrinkage rate, especially if you have tumor in the liver or in other sites where we really get concerned about the pace of the cancer taking off, is about 40%. So it can be a very effective drug. But it, along with another e-drug, enfortumab vedotin and sacituzumab govitecan, are options.
Say that again.
This will be on the test. Now, so there's enfortumab vedotin, sacituzumab govitecan. Both of those are.
Didn't help.
Didn't help. I was not sitting around the table when this was made up. But these are both called antibody drug conjugates. So those two drugs, as well as erdafitinib, also starts with an E, are available and FDA approved for patients that have had chemotherapy and have had immunotherapy and have disease progression. The dogma, again, decades ago, before I had the pleasure of meeting Diane and all the wonderful people at BCAN, was that we would try the same kind of chemotherapy or different kinds of chemotherapy over and over again in clinical trials, and they weren't very successful.
Right.
And, when we talk about research, I mean, this is really what happens, is that we understand what makes these diseases tick, why people develop cancers, or why the immune system that is supposed to recognize that a cancer is growing in your body, like, why is it not just fighting off the cancer? So understanding this with bench research helps us develop these drugs, which is really important. So antibody drug conjugates, in addition to erdafitinib, are agents that are very effective and can lead to responses, above and beyond what we see sometimes with immunotherapy and chemotherapy. So really, really hopeful. Those drugs are modern chemotherapy drugs, the antibody drug conjugates, but they are encapsulated little chemotherapy, called them smart bombs. So it's a chemotherapy drug, it's encapsulated in a vesicle, it's attached to an antibody, which acts like a magnet, and it seeks out, finds the cancer cells, and then actually injects the chemotherapy into the cancer cell, kills that cell and the cells around it, with a goal of not causing toxicity kind of throughout. So that's my very long answer to your very short question is, yeah, you, like others, I think, are experiencing some unique toxicities of this drug. And I think the hopeful thing is we have some drugs that are really effective and can be effective in the later line setting. Choosing when to give them and making them more tolerable, I think, is the next step.
Yeah. Claudette, I wore my stealth belt today in the pool. I'm not going to be on the cover of Sports Illustrated, but I did some laps. It's a great thing. I've been battling urethral cancer. And when I go to find information, oh, that's so rare, or I go down the dark Google and I find one study with 20 patients 15 years ago. Is there anywhere that you can recommend I find a little more information about that variant?
That's a difficult one. Urethral cancer is very rare. I mean, if we look at all urothelial cancers, with the majority being originating in the bladder, a subset then developing in the upper tract, we typically say around 5 to 10%. Urethral cancers are probably the 1 to 2%. So it's very uncommon. That's why you see these case studies of only, 10, 15, 20 patients, unfortunately. We do tend to treat it like we do with bladder cancer, where it's excision, is often the sort of the dogma that we use, simply because we don't know of anything else that we could particularly do to help it other than cut it out. As we surgeons say, we try to heal with cold steel, being the scalpel. But I will say that, it is a problem, particularly, for example, what do we do with somebody who has a urethral tumor who's already been treated with bladder cancer, who has a neobladder, right? Because if I take somebody's urethra out, where's the neobladder going to drain from? So then it becomes a very complicated situation. So there's a lot of nuances to it. And there's not a lot of data out there, I think, that is particularly patient friendly, simply because there isn't a lot of cases out there to provide some information on.
Hi, thank you all for being here. I'm very impressed. This is my first BCAN Summit, and I'm enjoying this a lot. Too bad I have cancer. But, so I have upper tract, and I had my kidney and ureter removed. I am definitely worried about losing my other kidney. I don't want cancer in that other kidney. I'll take my bladder. I don't care, but do not take my other kidney. So why don't we routinely do that aftercare chemo, or the injectable drugs, or let's get ahead of this cancer not try to chase it after it's metastasized somewhere else?
I'm gonna do this to you. So I'm gonna let you start with post nephew
Sure.
intravesical therapy.
Yeah, sure. So, so there's a couple scenarios, and I think that what you had sort of mentioned is what can we do to prevent this from happening in your contralateral remaining seemingly healthy kidney, right? So let's start first with a step further back, which is what Jeannie had alluded to before, which is probably a bigger issue, is your bladder, okay? Because of patients who have upper tract urothelial carcinoma, a relatively substantial proportion of those patients will subsequently develop bladder cancer. So you have to make sure that you're getting any patient with upper tract disease who has been treated adequately with, nephroureterectomy, whatever they've gotten, they should be getting routine cystoscopic surveillance of their bladder. And that's relatively easy to do. Again, nobody loves cystoscopies, but at least it's a relatively easy procedure to be able to evaluate the lining of the bladder to look for those bladder tumor recurrences. One of the things that we can do is at the time of the nephroureterectomy, your surgeon may have instilled the chemotherapeutic in the bladder to help reduce the risk of recurrence within the bladder itself down the road. And it's kind of like Jeannie was talking about before, you've got tumor in the upper tract and that's draining into the kidney. Well, if I start mucking around with that tumor and start manipulating the kidney as I'm trying to remove it, I'm going to really agitate all those cells and push those down into the bladder and potentially lead to seeding within the bladder that can subsequently manifest 3 to 6 to 12 months down the road with a new tumor. So one of our good friends, Dr. Ed Messing, came up with a trial that asked the question, what happens if we put a chemotherapeutic in the bladder at the time of nephroureterectomy? Could that reduce the risk of subsequent recurrence of bladder tumors? And the answer is yes, it does. So that is one thing, albeit a small thing, but it is a thing that we can do to help reduce the risk of bladder tumor recurrence after nephroureterectomy. Now, for the contralateral upper tract, what does that mean? The remaining kidney. It is very rare for someone to develop a metachronous tumor of the remaining kidney, but it happens. You can get immunotherapy, and I think I'm gonna shoot that back to Jeannie about what the indications are for immunotherapy after a nephroureterectomy. There's certain features that we look for on the nephroureterectomy pathology specimen that would make you eligible to receive that immunotherapeutic. And that really primarily is done to reduce your risk of recurrence of cancer that originated from that kidney that we'd already took out. It's not necessarily to prevent new tumors from developing in your remaining kidney, but it may be a little side effect that would be a beautiful thing, right? I mean, a little icing on the cake. But we don't know if that's really, if that is what's going to happen if you were to receive that immunotherapeutic. Right now, there isn't anything topical that we can put in the upper urinary tract. It's, as Jeannie alluded to before, it's a hard place to get to, and it's a hard place to inject stuff unless you have a tube coming out of your back where you can inject stuff, into it antegrade. It's not an easy area to access to provide topical therapies that potentially could act like a BCG, for example, that we can put in the bladder. So it's hard. And for a issue that typically happens pretty rarely, that's why I don't think that there's something there yet for that specific reason. Hopefully that makes sense.
It's like the cost effect,
Kind of, yeah, exactly. But there is reason to get sometimes adjuvant immunotherapy after nephroureterectomy, right?
Didn't you have somebody?
Oh, yeah. So that's for BC. That's something that is not current standard of care. But that is actually an interesting thought. Like, could you get something as a shot like BCG to enhance the response to intravesical therapy? That's interesting. In addition, from what I hear, and again, Jeannie can talk about this more, is that some of these immunotherapeutics, instead of having to get a systemic injection through an IV, I know that there is development of potentially an injection of an immunotherapeutic that could be given subcutaneously, so you're not having to come to an infusion center to get that. That's something that may make it more accessible for patients. But again, for your particular scenario, there's not currently something that we can give.
Thank you.
Next question.
I like to run.
I don't know. I just with the appendix question. I don't know if this helps. I will start with Dr. Campbell. He described my cancer as very angry. So he took the neobladder. The treatment didn't work, so I had a cystectomy. He took the neobladder off the table because he did not want to leave my urethra, and he took all my reproductive organs and lymph nodes. But he also took my appendix to lower my risk of reoccurrence in the first year. And I have a few more months left. So hopefully I will. But I didn't know. I mean, he took mine because it was susceptible.
Okay, so that just very briefly, and I'm glad that worked out. Right now, that isn't necessarily the standard of care to take out the appendix at the time of cystectomy. It is something that used to be done for any sort of pelvic surgery. You were getting your uterus taken out for something. You were getting your, your colon cancer surgery. Appendix, it was what we call an incidental appendectomy. You would just do it because you were there, and people are like, you don't really need your appendix, let's get it out, so patients wouldn't subsequently have to deal with appendicitis down the road. But right now, that isn't the standard of care because data never really sort of panned out for that. It never really seemed to make that much of a difference. And even though it's a small risk, you can have some issues with an appendectomy. That's why we don't routinely offer it. There could be scenarios where you do offer it. In addition, the appendix may be a sanctuary site for part of our immune system. So this is sort of me just kind of coming up with some theoretical nonsense, but perhaps, that could sort of, reduce some of your immune cells and maybe perhaps alter your immune response to subsequent treatment. I just made that up, but it is a sanctuary site of immune cells, and that could be a reason maybe not to take it out, but that's not something that we routinely do during cystectomy.
I have the microphone right now, and I was trying to wait to the very end to ask my question. Just to preference this a little bit, I have a neobladder. But thank you so much for what you do. I mean, I'm overwhelmed at all the answers that people are getting here today. Thanks to you, and thanks for you being here. But I have a question to ask. In what you do, and this thing is multifaceted, but in what you do, how many people that look like me are you treating?
How do you look?
Brown, Black, African American.
I think it depends on the center that you work at. At our center in Washington Hospital Center, which is, in near the, southwest corner of DC, we see a lot of African American patients.
With bladder cancer?
Absolutely.
And how many of them, if I can ask this also, come in with no insurance?
Ooh, I can't give you a statistic on that, but I'd probably say a minority. I'd say a minority. I mean, a lot of them, DC does have a lot of different options for our patients. So a lot of them do have DC Medicaid. So there are a lot of options for our patients, and often too, because they're coming to me at a point where they've been referred by another physician, for example. Often those issues, they may have come uninsured to their primary doctor, or they may have come uninsured to the urgent care ER. And then fortunately, we have pretty good social services within the district that then maybe gets them some coverage. And then by the time they get to me, they have something in terms of coverage. Now, whether 3 months prior to their first visit with me, whether they were uninsured, that's a great question. And I'd be willing to say that probably a good proportion of them probably have that scenario. A lot of them will come and say, oh, I have no health problems. Well, you don't have any health problems. You haven't seen a doctor in 40 years. So, that's when we start to uncover all kinds of things in people.
Jeannie, how about at Hopkins, either at Sibley or in Baltimore?
Yeah, I mean, I don't have the numbers, but bladder cancer in general is a disease of older white guys. You know, I think one of the things that BCAN does well is talk about something called disparities. And I'm thinking, like, is the definition of disparity not being an older white guy? Because, you know, there is economic disparity, there's gender. We know that women with bladder cancer, you know, tend to present later and get different care. We know that, you know, patients that are not white, maybe depending on where you come from, maybe get different care, all different kinds of reasons. But I think that I don't know if we can solve that problem. I think what, at least not today and not on this stage, but I think what BCAN has done is really put a flashlight on this and have people like Samuel Washington, who's a wonderful urologist on the West Coast, who thinks about this as like part of his career, and, you know, have stages and platforms to have these discussions, really open up the fact that there are these disparities and see what we can do to recognize them and overcome them.
Hi, thank you, doctors.
Waiting so long.
Thank you, doctors, for what you do. 10 and a half years after I had a cystectomy with neoadjuvant chemotherapy, I was diagnosed with upper tract disease. I had 2 tumors in my renal pelvis, and that was last year. So my question is, I can understand the tract where if you have upper tract disease and then you can get bladder cancer. How does it work the other way around?
I think it's a really good question. And I think that your question, all these questions that we don't necessarily have perfect answers for are really spaces where people like Lambros and I and others say that that's a problem. There's not a good answer to that. How can we answer that? And that's where clinical trials get built. And that's where patient interaction and these stakeholder discussions happen. But to kind of think about your question, I think, Lambros, you brought this up when he was answering your question, is that a urothelial cancer, you know, probably won't develop in a seemingly normal upper tract. But the urothelium is an organ, it's contiguous. And so if you have a tumor that develops in one place, it's possible that this contiguous organ could have changes in it that would lead you to develop other cancers in these locations later. And that's in part why surveillance is so important. Yeah.
Okay, I'll get surveillance under anesthesia every 3 months. I am Lynch positive with an MSH2 mutation. So as of my last surveillance, which was just a few weeks ago, I was pretty clear, with exception that I had some inflammation and some biopsies were taken that came back as metaplasia, slight dysplasia, mild dysplasia. And I have, obviously it's okay because my doctor has not called me. So I'm not too concerned unless he calls me and tells me, hey, Gail, we got to do something. So my question is about that's in my left kidney, what to do about the right to make sure. And I guess I'm talking about.
Yeah, I mean, can you hear me? Oh, there we go. Well, I mean, typically I'm assuming you've been getting surveillance scans also, CT urograms? Not, okay. So if you're able to get, in general, if we're able to get upper tract imaging with a CT urogram, that's a very good way to evaluate the upper urinary tracts and look for any small abnormalities. We'll often call them filling defects, where there potentially is a tumor that develops and the dye that goes through the urinary system doesn't fill a particular area that it should. That clues us in that something's going on. Because the alternative is having what you're saying, which, and this is again going back to why upper tract disease can be so challenging, is sticking a scope up a kidney every 3 months is exceedingly difficult because that requires a general anesthetic, and patients don't like it. It's a cystoscopy is a nuisance and it's not fun, but at least it's over in a couple minutes. I mean, putting a scope in somebody's kidney, for those who have not had it before, I mean, that can be several days of spasms and pain and bleeding and potential damage to the upper urinary tract. So that's kind of where we take a pause and say, listen, I need to have some significant indication for me to potentially traumatize this patient's upper urinary tract by sticking a scope up there. Now, again, could we potentially in the future, hopefully, maybe we could suck a little bit of urine selectively from the upper tract and send it for some special test that I may develop in the future? That'd be great. But right now we don't have that. And I think the surrogate is the imaging, like CT urograms, but some people can't get that. They may have dye allergies. They may have their kidney function may not be adequate enough to receive dye. So that's a bit of a problem.
We have time for.
That's really hard to answer. I can come back and we'll talk about that after offline.
We have time for one more question. Did somebody have? Yep, you've got it back there.
Yeah, I was curious. It's my understanding that targeted therapy and immunotherapy, they're relatively new technologies the past 10 years. And I was curious if you can speak to over the horizon capabilities and technologies that may exist in the next 5 years. Is that something that's accelerating in terms of the progress? And are you guys monitoring, like, I guess, late stage trials to inform what may be over the horizon? Can you speak to that?
Yeah, I think the good news is absolutely yes. And the field of urothelial cancer has just absolutely exploded. And I know I don't look that old, but I am. And but when I first started practicing, and treating metastatic urothelial cancer, we go to places like this, we give talks. I gave the same talk for 8 years. It never changed. There was nothing to change. And every time I give a talk, this week I've given 3 talks, and I'm like, am I up to date? Am I up to date? Like you're trying to kind of, it's constantly changing. It's almost impossible. It was one talk that I would give about everything. And now it's like, well, do you want a non-muscle invasive? What part of the disease do you want to talk about? This technology of antibody drug conjugates, I think of them like you put different Lego pieces together. Well, there's different companies making different Lego pieces. Trying to understand what sequence to put things in, combinations. There's a really exciting combination coming down the line that may change standard of care. Different companies, looking at different kinds of sequencing and other kinds of technologies. So I think that the way that we treat this disease today will look different in 5 years and in 10 years. Absolutely. Yeah.
Yeah. Just to add to that, there's also beyond just targeted therapies, there's ways that we deliver the drug. For example, when we do intravesical therapy, as people know in this room, we put a drug inside the bladder. We tell them to hold it for as long as they possibly can, and then you expel it within an hour or 2 if we're lucky. How about if we could put something inside the bladder that elutes chemotherapy for 3 to 6 weeks? That technology is now out there, and it's being studied in clinical trials. How about if we could impregnate a stent that could be put into the upper urinary tract and release chemotherapy or immunotherapy or something like that in the upper urinary tract, so that I don't have to go in and basically stick a scope in every time to inject a drug, or have somebody with a percutaneous nephrostomy tube hanging outside of their body. These are all things that are right now on the horizon, and I suspect will be available in the next 5 to 10 years. Drug delivery is different, targeted therapies, also thinking about things kind of outside of the box. Oncolytic viruses. Viruses infect cells. If we can get them to infect bladder cancer cells preferentially and kill them, that's another way that we can potentially, deal with a disease like non-muscle invasive bladder cancer. And that's something that's being worked on currently as well. So there's a lot on the horizon, and it's super exciting. I also used to give the same talk for maybe slightly less time, but I'm sorry. Yeah, I didn't mention blue light cystoscopy at all today. But no, so there's a lot of cool things out there.
Well, Stephanie's standing here. It's almost time to move on for dinner. I want to thank each and every one of you for this wonderful discussion.